Hi everybody, welcome back. We're now going to talk about end-stage renal disease and the different treatment options for end-stage renal disease. One of the big treatment options for end-stage renal disease is dialysis. And dialysis uses the principles of movement of fluid and molecules across a semi-permeable membrane from one compartment to another. So in peritoneal dialysis, this movement occurs through a peritoneal membrane. In hemodialysis, this movement occurs through an artificial membrane, which is typically the dialysis machine. Dialysis is typically started for somebody with a GFR of less than 15 mils per minute, so that's a pretty low filtration rate of the kidneys. And at this point, the patient has signs and symptoms of encephalopathy, uncontrolled hyperkalemia, and pericarditis. Other reasons for dialysis are AEIOU is a good way to remember, but acidosis, so when they have metabolic acidosis, excess K, the hyperkalemia again, intoxication or an overdose like a drug overdose, if they have overload, fluid overload, excessive fluid overload, and for uremia. And remember, uremia is where that nitrogenous waste is building up and affecting different body systems. So the physiology of dialysis is that you have the movement of particles from the blood to the dialysates, and that's related to the concentration gradient. So the movement is related to the principles of diffusion, osmosis, and ultrafiltration. So with diffusion, this is where you have solutes that move from a greater concentration to a lesser concentration. And this is where the urea, the creatinine, the uric acid, the excess electrolytes, they will move from the blood, which is a greater concentration, to the dialysate, which is a lower concentration. Osmosis is when you have fluid that moves from a lesser area of solutes to a greater area of solutes. So that's also used in dialysis to pull that water out of the blood and into the dialysate. So that water is going to travel to a higher area, a greater area of solute. And then ultrafiltration is where a pressure gradient is used to move fluid across the membrane. So kind of positive pressure versus negative pressure. A more positive pressure is going to push that fluid over to the lesser pressure. So those are kind of the different principles behind that movement, and that's pretty much how dialysis works, to rid the body of the waste buildup and filter the blood. Peritoneal dialysis is a less common type of dialysis. About 10 to 12% of patients use this type of dialysis, but it's been around for a really long time, since about the 1920s. And some people prefer this type. It's good for patients who want some involvement in their treatments. It's also good for people who have maybe a little more functioning of their kidneys. The nice thing is there's no vascular access device required, and it's good for people that maybe want to do it at their home conveniently while they sleep. And what happens with peritoneal dialysis is that the dialysis solution, the dialysate, is actually put into the peritoneal space in the belly. And then that is how the exchange occurs and the filtration occurs. And then that dialysate is then removed from the body. They do have to stick a catheter in place. So they will surgically insert the catheter through the anterior abdominal wall near the umbilicus. So it's a midline umbilical incision, and they'll kind of feed the catheter through into the peritoneum, kind of a tunneled type of deal to the puncture sites. There's these things called Dacron cuffs that anchor that tube into place and keep it from migrating. They also help to prevent bacteria from traveling down that tube, so they kind of have a dual purpose. here is some other pictures of what peritoneal dialysis looks like. So you can see the catheter, how it is inserted into the peritoneum here, into this space. The dialysis solution is put into the peritoneal cavity, and it will sit in there for a certain amount of time, and then it will be removed through the drain bag. So those are very basic principles of peritoneal dialysis. Here's another picture showing what that looks like. So you have the filling time where the dialysis solution is entered into the peritoneal space, and then the time that it dwells, where there is this exchange happening of the waste, and then drainage of that waste. So the inflow is when the initial fluid is put into the peritoneal cavity. That takes about 10 minutes roughly. The dwell time can be about 30 minutes. That's the time where you have the exchange of the blood and the dialysis solution. And then the drain time is about 15 minutes. So it can be about 55 minutes to an hour roughly for one exchange. One dialysis exchange is what they call it. The dialysis solutions can vary. They can have dextrose in them. They can be ecodextrin or amino acid based types of solutions. The inflow is typically around 2 liters. If the person is very large, then they can actually handle a higher inflow of 3 liters. And same is true for somebody who is very small. They will typically have to have a smaller amount of inflow, maybe 1 liter. There's different types of peritoneal dialysis. There's an automated APD type. There's a continuous ambulatory peritoneal dialysis, or CAPD. The automated cycler is nice. It happens overnight when the patient is sleeping. They can have about 4 exchanges per night happening. Continuous ambulatory happens during the day and it's done every few hours, which is good because it mimics more of what a kidney is filtering, what the kidneys are actually doing. For peritoneal dialysis, an important thing with this type is maintaining aseptic technique to prevent any infection. You can see that making sure everything is clean, making sure the catheter is clean. Those are all very important things if someone were to have peritoneal dialysis. And so many times people become very skilled at handling all these things if they want to do this type of dialysis at home. They learn a lot about aseptic technique and making sure they're preventing infection. But like anything, there are complications, and specifically to peritoneal dialysis, there are complications related to that type of exchange occurring in the peritoneal cavity. The first and most concerning complication is peritonitis. So this can happen if there is an infection that develops into that cavity. So you're always going to be watching patients for, any kind of increase in white blood cells, any rebound tenderness, cloudy peritoneal fluid coming out when it's draining. Those are all indicators of peritonitis. Other complications that can occur are exit site infections and bleeding potentially from the trauma of the catheter being in the peritoneal cavity. Abdominal pain is something with the amount of fluid that is in that space. There can also be outflow problems. There can be kinks that happen in the catheter, and this can be related to somebody if they have a full colon and they have all that space filled up. That can actually cause a kink in the catheter. Also hernias and lower back pain. There's potential for this related to, again, the amount of fluid that's in the belly. It's increasing the intra-abdominal pressure, and it's kind of forcing the organs to be pushed. Might push on the back, it might push on the a hernia that is happening. Pulmonary complications, another issue with peritoneal dialysis, again related to that fluid in the space, in the peritoneal space, pushing on the respiratory system, the lungs. It can lead to atelectasis and pneumonia because it's displacing the lungs, and so the lungs are at a decreased ability to expand. There can also be significant protein loss through peritoneal dialysis, lost in the dialysate fluid. And then there can be carbohydrate and lipid abnormalities that can occur with especially dialysate formulas that are dextrose based. That's going to increase blood sugar, and it's also going to cause carbohydrate lipid increasing. So those are your big peritoneal complications. Again, your most concerning is peritonitis. Hemodialysis is a dialysis given through a machine, and it's done about three or more times a week. Typically 3 times a week is a schedule you'll see most often, and it happens for about 3 hours each time. Hemodialysis can happen in a center or a outpatient type of facility that has trained staff, trained nurses and techs to do the dialysis. It can also be done in the home environment, which does require some support, some training, but it's nice too. It can be done at night during sleep for those people who might be interested in that. Dialysis is done in the hospital many times. You'll have patients that go off to the dialysis room and get their treatment while they're patients. Access for hemodialysis is very, very important. You have to have an artery with a rapid blood flow. So you have to find a large artery, which can be the radial artery. It has to be able to handle about 400 mils per minute of blood flow. And so with hemodialysis, they create either an arteriovenous fistula or an AVF, which is where you have arterial blood flow through a vein. So what they'll do is they'll find a large artery, and they will connect that artery to the vein, and anastomosis the artery and the vein together. And this will be the access device for hemodialysis. It takes about 6 weeks for this to mature, is what they call it, which means that it's going to dilate and the artery and vein are going to thicken, and that's to prepare that area for the frequent needle sticks and frequent use for dialysis. There's also an arteriovenous graft that they can do, and it's similar to the fistula. The only difference is that they use a synthetic material to bridge the artery and the vein together. So the mature time is a little less. It's 2 to 4 weeks. And the kind of big issue with arteriovenous grafts is that because they are synthetic material, there's a higher likelihood of clotting off. And so you have to worry about that clotting and becoming unusable at some point. They will use material like Teflon as the synthetic material. So they actually prefer to do the arteriovenous fistula. They feel like it's less likely to get infected. It's less likely to clot. So that's kind of the preferred access device for patients that need hemodialysis. And they will do an access in the non-dominant arm, typically is the best way to go, just because of, somebody who is dominant in a certain hand or a certain arm. They want to try and save that arm so that the person can continue to have normal movement. So other access devices can be more temporary, and they're typically put into the internal jugular. They can be put in the femoral vein. These are not IVs. They look sort of like IVs, but they're not. They usually have two different ports, one for the blood entering and one for the blood to exit. And they're highly, highly heparinized. And so it's really important that you don't use them as an IV, because there's a large bolus of heparin that keeps that line open. And so you don't want to push that high amount of heparin through and into the body. These are used in more emergent situations. They're not kind of kept for much time. They might be used temporarily while the patient is getting a fistula or a graft done. These ones can be high infection, can cause a high infection rate. They have a higher likelihood of clotting. They're just kind of uncomfortable. They're usually in an uncomfortable place, as you can see on the neck there. That's a kind of a bad spot, or on the chest. So these are when people are kind of waiting for a more permanent solution. This is kind of getting them by temporarily. So they will use, when they are accessing the hemodialysis, when they're doing the treatment, they're going to use a large needle, about 14 to 16 gauge needle, which is quite large. And they'll put one needle in that's going to pull from the circulation to the hemodialysis machine. And then there's going to be another needle placed that's going to return the dialyzed blood to the patient from the machine, the clean blood. And part of the assessment of that access device is to make sure that there is a thrill or a buzzing sensation that is felt by when you touch the access, the graft or the fistula. And there also must be a bruit, which is kind of a whooshing noise that you can hear through the stethoscope. So part of the assessment of that access area is to listen for the bruit and feel for the thrill. Those are two important pieces. And that's just indicating that the arterial blood is moving through at a high rate of speed and that it's working properly. The other important thing about the access area is that no blood pressures, no IVs, and no blood draws can be done on that arm. And this is to make sure that there is not any clotting or any infection that occur. So no BPs, no IVs, no blood draws. So typically you'll have to put a sign up in your patient's room to make sure that nobody touches that area, that arm, to do those things. The procedure for dialysis is the dialyzer, which is the long plastic cartridge, has thin hollow filaments, and they're made of that semi-permeable membrane. And so the blood is going to pass through those filaments, and the dialysis solution is passing in the opposite direction of those filaments, and there's going to be an exchange, and the waste products are going to diffuse from the blood into the dialysates. And then the filtered blood then will be returned to the patient. So that's a very basic way of understanding what happens in hemodialysis. At the end, when the patient is done and the filtered blood has been put back into the patient, you will have the needles will be removed, and then firm pressure will be put on the places where those needles were in the access device. So here's a diagram of what that looks like. You can see kind of how it works. So there's the pumping of the blood, and then there's the heparin that's also added to the blood to make sure that the blood does not clot off. The whole machine is primed with normal saline, and the blood is pumped about 200 to 250 mils per minute, so it's pretty fast. Okay, so talking about assessment when your patient's ready to have hemodialysis, an important thing to look at is how much weight gain they have had from their previous dialysis session to the next dialysis session. So the difference between the wet weight and the previous dry weight. And we really want to make sure that there is no more than 1 to 3 kilograms of weight gain between dialysis sessions. The reason for that is because if there is a higher weight, wet weight at the start of dialysis, that means it's going to require more fluid to be pulled off during that dialysis session. And that's going to potentially lead to hemodynamic instability. So we want to keep that difference of weight between 1 to 3 kilograms. The other important things to assess on the patient before they have dialysis is the site condition of their access, whether it be the fistula, the graft, the internal jugular site, the femoral site. Have to check that out and make sure everything looks good and that it doesn't look infected and it's not bleeding or anything. Also checking blood pressure to make sure the blood pressure is an adequate blood pressure. If somebody has a very low blood pressure, it would be concerning to go through with dialysis because you're pulling off even more fluid. So that is something that you have to kind of check and make sure the blood pressure is okay. They might require a bolus of fluids during their dialysis to increase the blood pressure. Lung sounds and heart sounds, also very important to see how much fluid volume is happening, the fluid overload in the lungs and the hearts potentially. A person in dialysis is going to have frequent vital signs, typically every 30 to 60 minutes. And at the same time, they will have their lungs rechecked and their blood pressure is the biggest vital sign that we're concerned about, obviously. And what about meds before dialysis? Do we give meds before dialysis? It kind of depends on what it is. If it's a blood pressure med, we have to be careful about that because we don't want to lower their blood pressure even more. So that would be something you may want to hold. The other thing that happens in dialysis is that the patient can have their blood sample taken. So if your patient needs blood samples taken by lab, that is a perfect opportunity during dialysis to have that done. Some complications related to hemodialysis specifically, the big one being hypotension. Again, we're concerned about all that fluid volume that is pulled off and causing hypovolemic effect. And what does your patient look like when they're hypotensive? They're going to be dizzy. They might have vision changes. They can also get nausea from that rapid removal of the fluids. And again, you might have to have them have a normal saline bolus to help with that. Or they might just need to have their dialysis slow down a bit, the amount of fluid that's being removed. The other thing that can happen is muscle cramps, and they don't really understand why or how this happens, but it's probably associated with that fluid shifting and from electrolytes shifting as well. Blood loss and hepatitis. For a while, hepatitis B was an issue with hemodialysis. That's not really been an issue since the vaccine for hepatitis B came about. We do still see hepatitis C associated with hemodialysis. Sepsis is another issue that can happen, complication related to an infection that gets into the blood and leading to a septic type of infection. Steele syndrome. Steele syndrome is related to the access of the graft or fistula or shunt. It's where there's an insufficient amount of blood flow because of the graft and the blood is shunted away from the peripheral or the distal extremity. And what you'll start to see is ischemia that will cause pale skin or numbness, poor capillary refill, and potentially pain. that is distal to the access site. So Steele syndrome is definitely an issue that you worry about with somebody that has a graft or fistula and is getting hemodialysis. So you have to keep checking to make sure that blood is not being shunted away from the distal extremity. Dietary kind of standards with the different type of dialysis. There's some slight differences. This is from your book. It's table 4610, talking about what the dietary requirements are for pre-end stage renal. We talked about that prior to this presentation. And then for peritoneal dialysis as well as hemodialysis. There's some different standards. For instance, for peritoneal dialysis, the fluid is basically unrestricted. And that is because people that are receiving peritoneal dialysis are controlled with their weight and their blood pressure being controlled, so the fluid doesn't have to be as restricted. The other thing with peritoneal dialysis is that the protein intake is increased. So these people on peritoneal dialysis can have a higher amount of protein than people that are receiving hemodialysis, and that is because there's a pretty significant loss of protein through the peritoneal membrane. And so you want to increase the person's intake to kind of offset that loss that's occurring. Calories, you want to have decreased calories, mainly because those dialysate solutions have dextrose in them, so they're adding calories for the patients. Sodium and potassium are not terribly limited, 2 to 3 grams per day for sodium and 2 to 4 for potassium, phosphate 1 gram per day. Just to kind of keep monitoring those lab values, and if the lab values are going up, then obviously we'd want to back off on the amount of sodium, potassium, and phosphate that the patient is having. So with hemodialysis, we do have a restricted fluid intake, and this is related to that limited weight gain between dialysis treatments of 1 to 3 kilograms. So we want to be careful about keeping the weight or the fluid to the urine output plus the amount of insensible loss. So whatever the urine output is and 600 mils of insensible loss. That's how we determine the fluid restriction for those with hemodialysis. Protein can be increased a little bit with dialysis to about 1.2 grams per kilogram per day. There are supplements that can be given. Nepro, microlipid, and amine aid are protein supplements. So with hemodialysis, the protein intake is slightly lower than what you would have with somebody on peritoneal dialysis. You also want to maintain adequate calorie intake, and phosphate, again, is about 1 gram per day. All right, moving on to the different types of continuous renal replacement therapies. So this is for somebody who is emergently needing dialysis treatment. This is somebody who is receiving this over an extended period of time, over 24 hours. It can actually end up being slow and continuous up to 40 days. So many of the critically ill patients will end up on a continuous dialysis to slowly pull fluid off and not do it in a way that creates a hemodynamically unstable situation. So that slow and steady kind of effect. Their access is usually a double lumen through the jugular, or they might have femoral access. And like I said, this is for people, they might have it up to 30 to 40 days to filter the blood. And a kidney transplant is another option. besides dialysis, once a person has been on dialysis for a while, they typically are working towards getting a kidney transplant. Unfortunately, many people die waiting for a kidney. There's about 100,000 current people on the transplant list. There's unfortunately a much higher demand than there is supply. 1-year survival rates, if a person does get a kidney transplant, is really, really high, about 90% if they're a deceased donor, and then greater than 95% with a living donor. So obviously we are looking for people who are living to donate their kidney, and the wait times for kidneys takes between about 3.5 and 5 years. The benefits to having a kidney transplant are that this can reverse those pathologic changes that have occurred in the body many times. No dialysis, no further dialysis is needed typically. And then this is also a less expensive way to go after the first year, once the transplant has happened, than to have dialysis. So transplant selection is a very important piece. As far as the recipient goes, there's an extensive evaluation of whether the recipient is eligible, if they have disseminated cancer, untreated cardiac disorders, chronic respiratory failure, and unresolved psychiatric disorders such as addiction to drugs. Those will cause a recipient to be ineligible for a transplant. So they will do an extensive workup, an extensive psychological evaluation. They also do HLA testing, human leukocyte antigens. They're checking compatibility and cross-matching. And there are live donors that receive extensive testing. If somebody is interested in being a donor, there are extensive labs that need to be done to make sure that the donor is healthy. There's a psych evaluation. They have to go before a committee, and the committee consists of doctors and nurses who then determine if the person can donate a kidney. If the donor is deceased, the transplant ideally needs to happen before the 24-hour period from the time of death, and this is considered the cold time between the time the patient has died and the time the patient is the kidney is transplanted into a new patient. They try to keep it about 24 hours or less. That is called cold time. So they want to cut down on the cold time because it will help with any complications afterwards. When they do a kidney transplant, they actually put the transplant in pretty low in the pelvic region, and many times they will leave the existing kidney in unless there is a problem with it, unless it has cancer. So yeah, they'll just leave the old one in and they put the new one in and reconnect. And that's kind of where the location is. You can see it's pretty low in comparison to where the kidneys typically are located. For post-operative care, for the live donor, it's important to monitor their renal function, but the biggest thing for them is pain control. So there's typically a lot of pain after a kidney is removed. The donor will have more pain than the recipient. There's not many other complications, and the patient must not lift anything for about 4 weeks, not exercise for about 6 weeks. On the recipient side, it's really important to monitor the fluid and electrolytes. And in the beginning stages, once the transplant has occurred, there is a significant amount of diuresis occurring. Why is this occurring? It's because there's this new ability to filter the BUN, so it's pulling fluid out, and there's a lot of diuresis happening. You also can attribute this to the amount of fluids that are given during surgery. And then also there's an initial amount of dysfunction in the kidneys that can occur when they're trying to get adjusted. And the kidney may not be able to concentrate that urine as well in the beginning. And so there's that diuresis happening. And so we're talking about about 1 liter per hour of diuresis typically, and that's normal after a transplant has occurred. We want to make sure we're preventing any renal hypoperfusion. We want to make sure those kidneys, the new kidney, is getting the proper perfusion. Acute tubular necrosis can occur, and this happens more commonly in cadaver donors or deceased donors when there's a prolonged amount of time that the kidney is out of the body before it's transplanted. It's going to increase the amount of ischemia that's happening. This person receiving this cadaver donor may need dialysis initially to kind of help with that. A concerning sign would be a decreased amount of urine output after the transplant. And so this would be a cause of worry. It can be related to dehydration, rejection happening, a leak of some sort, could be obstruction like a blood clot. So a decreased amount of urine is definitely cause for worry. Other complications that can happen after a transplant is rejection, and there's 3 different types of rejection. There's hyperacute rejection that can happen within minutes to hours of a transplant. Unfortunately, it's irreversible. There's not much that can be done once a hyperacute rejection has occurred. Acute rejection is another type that can be reversible, and that is by giving the recipient more immunosuppression medications, and that can usually reverse that acute rejection. The third type is chronic, and chronic is irreversible and slow over time. It's the immune system damaging the kidneys slowly over time, and unfortunately these patients end up kind of in the same place as they were before the transplant. They may end up back on dialysis. Infection is a big complication after transplantation due to the immunosuppression that's happening with the medication they're receiving, due to the end-stage renal disease, the body being an end-stage renal disease. The most common type of infections that occur are the post-op infections. So pneumonia, possibly wound infections, any kind of IV infection, or UTIs. Those are your most common types that occur once a person has received a transplant. Cardiovascular disease can come back, and so the person who has received this new kidney needs to continue to control their risk factors and to handle that cardiovascular disease, doing everything they can to prevent that. Malignancies is another complication, and that again is related to the immunosuppression that is happening in the body, all the anti-rejection medication that's given, the steroids. And finally, reoccurrence of renal disease may happen even in a transplanted kidney, might end up in the same boat and needing dialysis again. The signs and symptoms for rejection are going to be that urine output decreasing. That's definitely a sign. If the patient's BUN and creatinine are increasing, that's another indication. If they're having fever and tenderness over the kidney, the white blood cells are going up. Weight gain, which indicates fluid retention, increasing blood pressure, those things. So these are all important signs of rejection, and really, really important to monitor our patients for and keep an eye out for them. And I just want to mention too, some people actually choose not to have any kind of treatment for their end-stage renal disease. They manage the renal disease by medication, so they are medically managed, and eventually they do have the uremia and all of their body systems become affected. And so I just want to say that some people do choose to go down that direction and not to have any major interventions to treat the end-stage renal disease. Okay, I want to share with you a couple of YouTube videos related to kidney donation. So let's check these out real quick. They're very short, and then we'll be done.
Two years ago, I was sitting right where you are, having no idea that my life was about to change forever. I listened intently as the speaker told the story of a heroic stranger who saved her brother's life by giving him her kidney. Now, this wasn't the first time I had heard of kidney donation. My own sister Sarah donated her kidney to our stepdad 15 years ago when he was dying of kidney failure. So she only has her right kidney. As a nurse, I've watched patients grow sick and weak and lose hope and die of kidney failure. And with this experience and with the example my sister set so many years ago, I never thought of donating an organ while I was still alive. In the U.S., around 100,000 people are waiting for a kidney transplant. For perspective, that's the population of Boulder. Every day, 3,000 people are added to that list, and 13 people die waiting. Each one of them is someone's sibling or parent or child or friend. And while they wait, many of them spend what little energy they have on dialysis. That's a process where some of their blood is removed, the toxins are filtered out, and their blood is put back in. Well, guess what? Most of us can live normal, healthy lives with just one kidney. We have this amazing gift of life just sitting inside of us, yet only 5% of the kidneys needed come from living donors. My only surgery ever was November 28th, 2017, when I donated my left kidney, also known as lefty, to a stranger. The person who got my kidney had someone who would have donated to them but wasn't a match. That person donated to someone in a similar situation, and so on, so that 3 people got new kidneys that same day. The power of donating to a stranger is that my kidney donation started a chain reaction of surgeries where those willing to donate to a loved one were able to pay it forward. Funny thing is, I feel like I'm the one who's benefited most, and so right now I'd like to share a few lessons from Lefty. For starters, if you ever need a kidney, you get to jump to the top of the 3.5-year wait list because you already donated one. Not only that, everything's paid for before, during, and after your surgery. And who doesn't like free healthcare, right? If you're looking to lose weight, Lefty weighs about 5 ounces, and you'll never get that same 5 ounces back. Your friends will make you amazing, incredible food, and sometimes they'll even make it shaped like kidneys. You belong to a very exclusive club. I have a growing group of friends that are all kidney donors. Many of us volunteer for an organization called Go Save a Life to raise awareness for live kidney donation. If you want to join us, you know what you got to do. You can have a kick-ass theme party. Lefty worked hard to filter Rio margaritas for over 20 years, and I knew that Lefty needed to have a final farewell at the Rio. My party was 3 days before my surgery, which was the same night as Boulder SantaCon. Don't worry, you can still drink after you donate your kidney. And I secretly hope that the person who now has Lefty inside of them has found a new, unexplainable love for margaritas. And Santa. I teach nursing at Front Range Community College, and I got to see my hard work pay off. A few hours after my surgery, the nurse came in to do my full-body skin check. It was only after that total exposure I realized she had been one of my students. Awkward, but the best nurse I had. When you tell people you donated your kidney, you'll realize that it's amazing how your kindness inspires kindness in others, and it's true, kindness is contagious. On a side note, it can make for a great pickup line. And get this, research shows that being a kind person is better for your health than regular exercise. No joke. You'll also have cool scars to show off when you exercise, because even though you're a kind person, you should still exercise. The National Kidney Registry in the past years had 113 altruistic kidney donations, and our kidney chains have resulted in over 300 kidney transplants so far. Tonight, I'm here with 3 other donors, and one of our recipients. My incredible sister saved my stepdad's life 15 years ago, and that's amazing, but there are still thousands and thousands of people waiting for a kidney. So I'm not saying that everyone here should be compelled to run out and donate lefty, though that would be amazing. What I am saying is you never know when a 5-minute night talk will change your life and maybe save the lives of others in the process. Thank you.
Okay, and then I have one more for you about kidney donation, and this should only take about 2 minutes.
Imagine you're sitting in a boat wearing 2 life jackets. You realize a person is drowning in the water next to you. Will you give them your extra life jacket to save them? How about your kidney? In the US, 95,000 people desperately need a kidney. Each year, kidney disease kills 2 million Americans. That's 28 times the number of people who die from breast cancer and prostate cancer combined. But get this, you can donate your spare kidney and save a life, because you only need one of them. Even if you're a registered organ donor, fewer than 1 in 500 donors die in a way that organs can be transplanted. 100,000 people need this life-saving transplant, but each year fewer than 200 people donate their kidneys to a stranger. That's fewer than the number of astronauts who have been to the International Space Station. Why? Because there's one thing people don't know. Your donation could save multiple lives. Though thousands of people receive donations from friends or family every year, many others don't have a match. This leaves a chain of matched pairs waiting on your donation to set off the reaction. Living kidney donation is the gift of life and is entirely paid for by the recipient's insurance. Consider saving a life and share your spare.
Okay guys, that is all I have for you on our kidney units. This wraps up our Unit 1. Hopefully everything makes sense. If you do have questions about any of the contents from today, just feel free to email me and we'll clear up any questions you might have. And hopefully this will kind of make you think a little bit about kidney donation too here, this shameless plug here at the end. All right, thanks.